Thanks to all for the kind introductions and the opportunity to be able to present at this forum today. We're going to talk about pregnancy and conception issues for women living with HIV. So women who are HIV positive and thinking about pregnancy, what are some of the issues that we as clinicians need to address? So I'd say, first of all, it really starts before they are planning pregnancy and the whole idea of preconception planning and counseling. And this really needs to start with the first visit of an HIV-infected woman to the clinic. And in my experience, when women are newly diagnosed with HIV and they come for their clinic care, that's one of the first questions in their mind. Am I ever going to be able to have a baby? And so I think it's really important that that happens right up front. And I think part of that discussion with the women is, will pregnancy negatively impact the HIV, or will HIV impact their pregnancy? And then I think as we go on, there's a number of other questions that we're going to address. What is the right combination antiretroviral therapy for women of childbearing potential? What do the guidelines say? And then what are the risks to the baby from HIV itself, from antiretroviral therapy, or from specific agents? So as I alluded to earlier, these whole reproductive goals should be discussed with women right at the time of their HIV diagnosis and then reviewed annually, because opinions and considerations do change along with the course of a woman's HIV disease. And I think one of the first things I always share with women is that HIV is not going to negatively impact your pregnancy. And if you are able to successfully take antiretroviral therapy and have suppressed viral load at the time of delivery, then your baby should be fine. The other thing that's important for them to realize is getting pregnant is not going to have an impairment on their HIV. And although pregnancy in itself does cause a decline in CD4 counts, even in those who are not HIV infected, that generally returns to the normal status after the pregnancy is completed and will not negatively impact their HIV progression. So when you have your woman in your office, it's important to review their pregnancy history. Have they ever been pregnant in the past? What was the outcome of that pregnancy? And you want to review their menstrual activity to determine whether or not there is a good likelihood that they're going to be able to become pregnant through normal sexual activity. And like all women, whether they're HIV infected or not, when you're thinking about pregnancy, you need to consider what are some of the underlying illnesses or medications that may need to be altered should a woman become pregnant. You want to treat and diagnose any sexually transmitted infection. And for women in particular, you want to do a pap smear and make sure that there is no cervical dysplasia that requires therapy. It's a good time to review smoking and drug use, and the use of mental health and other supportive services where necessary. And again, if a woman is thinking about pregnancy, now's the time to start that folic acid supplementation. And ideally, you want to do that a few months before they consider becoming pregnant. So why is it important to think about the choice of antiretroviral therapy in women of childbearing potential? Well, first of all, we don't have all of the safety data that we need for most of these drugs, largely because pregnant women are generally excluded from antiretroviral trials. And the experience of drugs in pregnancy usually comes when women inadvertently become pregnant on different drugs, and then we try to collect cohort data. The other issue is that usually by the time a woman recognizes that she's pregnant, she's beyond that initial stages of gestation where drugs may have their maximal teratogenic effects. The other thing that you need to discuss this is because of some of the efficacy considerations, and Katrina is going to talk a little bit more about this, but some antiretroviral drugs have lower drug levels, particularly late in pregnancy, which could impact the risk of loss of viral control and subsequent transmission to a baby. On the other hand, if women are trying not to get pregnant at this time, it's really important to understand that there can be significant drug-drug interactions between the oral contraceptive drugs and some of the antiretroviral agents, which may or may not decrease the activity of the contraceptive agent. So again, this needs to be discussed prior to that decision point. I think it's really important to recognize that the vast or many or up to half of pregnancies in HIV positive women are unintended. And this was a study that I had done with one of my colleagues, Dr. Mona Lutfi, many, many years ago, looking at women who had been diagnosed with HIV or not, and determining whether or not their last pregnancy was intended or not intended. And you can see that about 50% of the time pregnancies are not intended. And similar data has come out from the Swiss cohort study. Again, this is a few years back, but stating that a significant number of women were not using contraception and a number had unintended pregnancy. And this is further magnified by a study in South Africa where up to 71% of the pregnancies were unintended. So we need to think about our antiretroviral choices for women of childbearing potential in the potential that they may become pregnant over the next few years. There are some ethical considerations as well. And if you look at the DHHS guidelines, they really try to distinguish women who might become pregnant and women who are actively trying to conceive. But I think that a lot of the information that we've learned about drugs in pregnancy recently, that it's really important that we involve women in these decisions and that we counsel them and we allow them to make informed decision-making with respect to which antiretroviral drugs that they're going to use in a non-coercive and respectful partnership, which allows her some autonomy in her decision-making process. And it's really important that we don't restrict choices of antiretroviral drugs in women of childbearing potential, because we really got to consider their own health as well. And it's really important that we make sure that these women are well controlled within themselves and that they achieve viral suppression. And we have to remember that for many of the drugs in pregnancy, we don't have good information. And the lack of information doesn't mean that they're necessarily safer. So then if you have a woman who is trying to conceive, what are her options? And I think the primary recommendation now that if a woman is safely on antiretroviral therapy with a suppressed viral load, then we do believe in the concept of U equals U, and therefore the optimal way for her to attempt to get pregnant is through condomless sex. And if you time this with ovulation decisions, then that may increase the likelihood of her becoming pregnant. We do not find any role for PrEP under these circumstances, and that the additional role of PrEP in her partner, there is no evidence that that will add any further protection. What are some of the other options? Some other options are artificial insemination, either doing that at home, the so-called turkey baster approach, or perhaps through a fertility clinic, either with the use of sperm washing with intrauterine insemination. And then there are other options should a woman not be able to become pregnant naturally, including things like in vitro fertilization, intracytoplasmic sperm injection, sperm donor, egg donor, and ultimately adoption. Now, when discussing these options, it's really important to consider the circumstances. And obviously, we need to consider the availability that many of these services cost, and many of them cost a lot of money. There can be different cultural beliefs of the woman with whom you're having these discussions. You need to think about personal risk evaluations. And there are some women who are very risk adverse, and despite our advice and counseling on U equals U, may not want to take that approach if they have any concern about transmission to the partner. You also need to consider their clinical circumstances. Is a woman approaching the menopause? Is her options for getting pregnant going to be limited over time? And then obviously the woman's own preference for the approach has to be most important. So when you're thinking about antiretroviral agents in women who are trying to conceive, we need to think about what are the drugs that are going to optimize health of that woman? What are the agents that are going to minimize the risk of any transmission? What are the ones that are going to be safest? What are the ones for which we have data in pregnancy? And again, preventing sexual transmission to the partner without HIV infection. So when we think about choosing antiretroviral drugs in pregnancy, it's best to start drugs before pregnancy. And obviously in today's world, the approach is if you have HIV, you treat it. So most women, unless they get diagnosed during pregnancy, will likely be on antiretroviral drugs before they become pregnant. And we must remember that pregnancy is not an ideal time for switching. That often in the early stages of pregnancy, women feel unwell, they feel nauseous, and if you start switching antiretroviral drugs, then it becomes difficult to know if some of these adverse events may be due to the pregnancy versus the antiretroviral drugs themselves. The key is what you want to achieve is suppression at viral load at delivery, as this is going to decrease the risk of transmission to that baby. As I alluded to before, the data on the vast majority of antiretroviral drugs in pregnancy is limited, and so we have to make choices based upon what we do know at the time. Timing is also exposure, and if we're worried about teratogenicity, then that issue becomes most important at the very early stages of pregnancy, and as I alluded to before, often before a woman even recognizes that she is pregnant. And again, there's many pregnancies that are unintended. The problem when we review the literature, and particularly when we review the pregnancy registries on the safety of drugs in pregnancy, is that we often use them in combination. And therefore, how can we be certain which agent of the combination might be responsible for a particular adverse event that has been recognized? As I alluded to before, switching can be difficult, and switching can lead to new adverse events. These new adverse events could lead to impairment of adherence and ultimately viral failure and potential transmission. So you really need to balance what is known or not known against the toxicity of the drug versus the risk of switching. Katrina is going to talk in this second section about the PK of certain agents, which may not support their use in the prevention of maternal-child transmission, particularly things like cobicistat boosted agents and TAF. And then another consideration to give is that women with HIV, like the general population, may develop postpartum depression, and this may influence the agent that you choose as well. So drug therapy in pregnancy really becomes a balancing act between the benefit of treatment to the mother versus the risk of fetal adverse events. And as I alluded to, most of the time we have limited data upon which to make these recommendations. The other thing that we need to remember is that HIV itself can be associated with poor fetal outcomes. And often when we're looking at and evaluating these studies of different antiretroviral drugs, it's very difficult for us to adjust for the HIV factor. And this is a publication now by Rebecca Zash and her colleagues in JAMA Pediatrics in 2017, looking at adverse events of pregnancy in blue, any adverse outcome at all, such as small for gestational age, neonatal death, versus severe outcomes, which are shown in orange. And as you can see, we're looking at the different types of antiretroviral drugs that were used in pregnancy, but you also need to compare HIV infected to HIV uninfected, and that we always need to consider that there is this HIV factor. That being said, however, the risk of transmission of HIV in a woman who was not treated far outweighs any potential disadvantage of using drugs in pregnancy. So it is recommended that all HIV-infected women who are pregnant go on suppressive antiretroviral therapy. Now, is there a safer drug? Is there a class of drugs? Is there a drug that's safer? And I think that this is a question that has been there since women have started on antiretroviral therapy in pregnancy. This is some of the older data from Europe and Asia looking at the risk of preterm birth. You can see the first bars, not on antiretroviral therapy, really not that different. A single drug, again, not that different. But as we start to use combination therapy, we started to see more issues in those women living with HIV relative to the general population. And do pregnancy outcomes really vary by antiretroviral regimen? And again, this is back to the data from Zash and company that suggests that some of the agents may be associated with more adverse events in the fetuses than others. Again, these are difficult to compare because there's other circumstances such as smoking, malnutrition, weight that may influence these outcomes. But compared to efavirenz, which was an agent that we used to think was not associated with adverse outcomes, some of these other combinations do appear to have higher poor outcomes in babies. So we all have heard lately of the issue related to dolutegravir, and I think that this scenario really outlines the importance for us in evaluating properly the safety and efficacy of antiretroviral therapy in pregnancy. And I think many of you are aware of the TSAMO study, which was evaluating the impact, initially designed to look at the impact of efavirenz on fetal outcomes. But with the change in the recommendations by the WHO in terms of antiretroviral therapy in the developing world, it ended up being a comparison of efavirenz in first trimester of pregnancy versus dolutegravir. And many of us will recall in May of 2018 that there was a signal that perhaps there was an increased risk of neural tube defects in those pregnancies that were exposed to dolutegravir early in the pregnancy as opposed to efavirenz or other antiretroviral regimens. And all of us received a warning that came out that perhaps we should not consider the use of dolutegravir in pregnancy. But what happened was that they continued to follow this cohort over time. And by April of 2019, with another year of data, you can now see that the difference between dolutegravir versus non-dolutegravir regimens, which was 0.94% in the first evaluation, had now dropped to 0.30%. This cohort was continued to be followed. And again, by April of 2020, now the comparison is 0.19, suggesting that the difference in neural tube defects between pregnancies exposed to dolutegravir in first trimester versus efavirenz had all but disappeared. And if we look at the absolute risk, you can see the dolutegravir arm, it's 2 out of 1,908. And if you look in the efavirenz arm, 5 out of 3,000. And so it was really important that we continued to follow this data over time to recognize that although there may have been an initial signal, in fact, there was no increased risk of dolutegravir relative to efavirenz in first trimester of pregnancy. What about some of the newer agents? And we recently learned at CROI this year from the IMPACT study that was looking at dolutegravir versus efavirenz, and the new formulation of tenofovir alafenamide versus tenofovir drug in pregnancy. Now, I would like to point out the fact that this was a study of women who were pregnant who had been antiretroviral naive before pregnancy, but that these agents were started a little bit into the pregnancy, on average between 14 and 28 weeks of gestation. And the point of this study was really to look at the safety and efficacy of these different regimens during pregnancy. And what we can see if we look at response rate, which we can define as women having less than 200 copies of virus at the time of delivery, you can see for the dolutegravir-based arm, it was 96%, for the efavirenz-based arm, also 96%. If we look at the number of women who had virologic failure at any point after 24 weeks on pregnancy, it was 4.1 in the dolutegravir and TAF arm, 5.1% in the dolutegravir and Truvada arm, as opposed to 10.4% in the efavirenz arm. If we look at the impact on the fetus, this study is looking at grade 3 adverse events, either on mother, on infant, looking at infant deaths, also looking at stillbirths. Again, that we can see in this circumstance that the dolutegravir TAF FTC arm appeared to be superior or was better than the dolutegravir or the efavirenz arm. And although there were some major congenital abnormalities, as you can see them listed there, there was nothing that was consistent, and there was nothing that was found to be larger in one group over the other. So there were 4 infants who did have HIV transmission during the study. You can see the details of those studies now. And in 2 of those cases, they were women who had detectable viral load at the time of delivery. In the other 2, there was not. But there was no relationship found between HIV infection in the infant and the maternal ART regimen. So what do the guidelines now tell us in terms of the initiation of antiretroviral therapy during pregnancy? So these have changed quite significantly now. And if we look at the NRTI backbone, you can see that either tenofovir or abacavir in combination with 3-TC is recommended as the preferred agent. Combivir continues to be an alternative drug. And at the time of these recommendations, there was insufficient data to recommend TAF, but based upon that impact study, we may find that that changes. In terms of the integrase inhibitors, despite the initial concerns around the Tesano study, everything has changed now, and dolutegravir and raltegravir are both considered to be preferred agents in pregnancy, whereas bictegravir is still put in the category that there's insufficient data to make the recommendation, just simply because we do not have data. If the woman requires protease inhibitor for her own health, then the preferred agents are either darunavir or atazanavir in combination with ritonavir, with Kaletra being the alternative drug. As I alluded to before, don't forget that women may become depressed during pregnancy and suffer from postpartum depression. This is a study from Uganda suggesting that relative to non-pregnant women, that pregnant and postpartum women may have a higher risk of depression, and that this needs to be considered if efavirenz is going to be a drug that is going to be considered for use in pregnancy, and whether or not this may be exacerbated. Lastly of all, there are some issues that remain around delivery. Do we use vaginal or cesarean section? And I think most of the guidelines now would suggest that if a woman is suppressed at the time of delivery, that she can safely deliver by the vaginal route without any risk of increased maternal-child transmission. The issue there, however, is that in many circumstances, do we really know whether the woman is suppressed or not? And so it's really important to have the woman being seen frequently during during the course of her pregnancy, so that that information is available at the time of delivery. Which begs the question, is there still a role for intravenous AZT? And again, it's the same issue, is if the woman is completely suppressed at the time of delivery, then there is no additional role for intravenous AZT, but this has remained in the guidelines because many of the cases we really do not know, particularly if a woman's been non-compliant with follow-up or with their therapy, as to whether or not she has suppressive viral load at the time of delivery. So the question is, how long ago is acceptable? So clearly, if there's a woman that you've been following in your clinic and she's been suppressed every month, then I think that's adequate. If you haven't seen the woman for the last 6 months, then unfortunately you don't know she has suppressed viral load, and then you have to consider both the cesarean section and the role of intravenous AZT. Should she breastfeed or not? Well, obviously, this is another controversial issue in the developed world where we have alternative and safe forms of food supplementation. It is generally recommended that women do not breastfeed. But as we know, in many parts of the developing world, breastfeeding is very important in order for infant nutrition and for safety. And again, that's another topic in a big area of controversy that we won't have time to go into today. And then lastly, another important question is in terms of follow-up of the mother. And many studies have shown that a busy mom with a new baby is often appearance of non-compliance for her with her visits, as well as her taking her antiretroviral therapy. And perhaps if the COVID epidemic has done anything for us, it's increased the incidence of virtual care. And perhaps this is a really good opportunity for virtual care for us to check in with the mom to make sure she's doing okay, making sure she's taking her antiretroviral therapy and considering her own health and not just that of her newborn. So I'm going to conclude there, and I'm just going to highlight a few points of my discussion. Is first of all, family planning should be discussed with all women with HIV of childbearing potential. That should happen with the first visit and should be reviewed on an annual basis. Antiretroviral choices should maximize the maternal health, but also minimize any risk to a potential fetus, be that a planned or unplanned pregnancy. The safety of most of our antiretroviral drugs in pregnancy is unknown, and data lags many, many years after drug licensure. And again, I warn you that the absence of data does not mean that a drug is safe. But I want to conclude by saying that the prevention of mother-to-child transmission through the use of antiretroviral therapy has clearly been one of the biggest success stories of ART and needs to be recommended for all women living with HIV. I thank you for your attention and look forward to your questions.